Good morning, everyone. Welcome to our Department of Pediatrics Grand Rounds. My name is Suresh. I'm with the Divisions of Emergency Medicine and Health Informatics. It's my pleasure to introduce our Grand Round speaker today, my informatics colleague, Dr. Emily Weber. Dr. Weber is the Chief Medical Information Officer at Indiana University Health and Riley Children's Health in Indianapolis. She's an Associate Professor of Pediatrics at the University of Indiana and a practicing pediatric hospitalist. She's board certified in pediatrics, pediatric hospital medicine, and in the growing specialty of clinical informatics. Dr. Weber graduated from Indiana University School of Medicine and completed pediatric residency and chief residency at Children's Hospital Los Angeles and at the University of Southern California. Having worked on many IT implementations, Dr. Weber is focused on working on a high reliability culture in applied informatics, promotion of safe and equitable data exchange, and patient digital experiences that improve clinical outcomes, specifically in telemedicine and digital health equity. She is also a Regent Strife affiliate scientist and is the immediate past chairperson of the American Academy of Pediatrics Executive Council on Clinical Information Technology. She serves as a member of the Cerner Pediatric Leadership Council and a member of the American Medical Informatics Association. Dr. Weber is very active on social media, and she can be found on Twitter as @PedsHospDoc. She's really one of the leading academic informaticists nationwide. I will now turn it over to Dr. Weber, who will talk about medical ethical challenges in artificial intelligence and other applied technologies. Dr. Weber, welcome.
Thank you so much. Thank you for the invitation to be here and share what I'm really excited to speak about today. As with all technology talks, I'll appreciate your help and your questions, and I hope we'll have a really interesting discussion. And I will go ahead and get started. Okay. Like many pediatricians, I have no financial disclosures. I do practice at Riley Children's Health in Indianapolis, Indiana, and we are the quaternary care children's hospital for our state, also associated with our large medical school. So actually very similar to all of you at Children's Pittsburgh and UPMC. And this has really given us a chance being Riley Children's Health. We're also connected and are part of Indiana University Health, which is the largest provider in the state of Indiana. And so with that work has really given me a chance and my colleagues a chance to really get into the meat of what we're talking about today with artificial intelligence, augmented intelligence, and really, really excited to be here representing IU and Indiana with you all today. So as Suresh mentioned, I'm really passionate about this topic. I practice as a pediatric hospitalist and then also in my informatics role. And what we're seeing more and more is the evolution and emergence of artificial intelligence. So today I really want to talk about what does that mean? What does that mean for our patients? And what have we actually been seeing? This is a very pulled from the headlines kind of thing. So I hope you'll all find it relevant to your work. And then how can we as clinicians and pediatricians particularly think about what we already know about biomedical ethics in those situations? So lots of case studies today. But as a primer, let's start with what artificial intelligence is. And so if you are not familiar with AI, you're probably actually already using it in your everyday life. But AI refers to anything that is an application or software that can learn, adapt, and predict. Machine learning is a type of AI. So that means that, and there's a huge range, right? You can actually tell a computer what rules you want it to learn. You can also, give AI data to learn patterns. And what really distinguishes machine learning and AI from what human analysis is that the amount and breadth and depth of the data can be really different. So these programs can do things that we as humans simply can't intake as much. And that's a good way to think about it. The learning styles of these softwares can be supervised or unsupervised, and they can also be reinforced. And I really like this description because when you really start to think about AI and how you predict and check things, there's a famous quotation from John McCarthy here that I'll share. The science and it's all the way back from the 1950s, but it still rings true. AI does not have to confine itself to methods that are biologically observable. And what that means is that we can't necessarily see and check what AI is doing for us. And if that's not a little exciting and a little scary, I don't know what is, because we in healthcare in particular, we pride ourselves on evidence-based, reproducible types of things. And when you can't check it, that's essentially where we are in AI. Now, that being said, I'm borrowing some of these ideas from some of my colleagues who've been working in this area, and this is from Dr. Rebecca Winokur. But this can be really helpful. This is not a bad thing because it can really help reduce cognitive load. So AI is in the range all the way across from data capture, like voice, image, and sensors, to speech to text and image recognition, all the way to something that might be in your EMR already. We use Cerner where I work, so this is a adapted slide from them. Another way to think about this is transforming it. So AI can range from descriptive, so observing, recording. So think of a virtual scribe, for example, to predictive. So this might be an algorithm that's going to predict sepsis or another kind of clinical problem, to prescriptive. What medicine should I use? So it's a real in my practice every day. So I'm going to keep going. This is from Callis et al. There's a lot of AI and machine learning already in healthcare. This is from review, even from a few years ago. And you can see at the top of their list at that point was robot-assisted surgery and virtual nursing assistants, but which always sound very sci-fi fabulous. But if you look at the administrative workflow and other types of things that are already around, these are actually probably embedded. So think about billing, think about scheduling and things like that. These things are actually probably already around. So if you start to turn that around and you're like, oh my goodness, it's already here. What does this mean for my patients? Am I being thoughtful and responsible about how I'm using their data? There's a construct you can use kind of practically to think about this. And this is just a construct that we've put together at my institution based on others over time as well. So there's a range of intelligence. You can start to ask questions like, what is this technology doing? Is it observing outcomes? Is it detecting patterns? You can ask a very simple question. Did a human write the logic rules, or did it adjust on its own? Are there checks? Can programmers check in and see how much has been adjusted? And then probably this is the real hard one to get your brain around. Does the way the machine works mean something to a human observer? This goes back to that first quote about does our is it can actually understand, or is it just beyond into it? So this is just a way to start to get your mind flowing. But I would also just be aware, there's a lot of marketing AI space in health technology now. So if you hear people throwing around words like cloud technology, Internet of Things, it's all in the cloud, be kind of savvy and skeptical there, because these are not solutions in and of themselves. These are descriptors of things, not solutions. When you think about AI and ML in healthcare, this should raise other kinds of ethical questions in your mind as well. So you think about data confidentiality, security. The rules we use for things like HIPAA, these are decades old, but how do you de-identify someone's genome, for example? If you think about patient autonomy, what do you do? How do you consent a patient and make sure that their choices are, or if they're using something that uses AI? And then finally, how do you consent, and how do you make sure that they know what they're doing? And then I'm going to get a little bit into representation on data sets here in a moment. Just as a quick touchstone, if your mind is swirling at this point about what's an ethical choice, you'll want to think through that in these terms here. You can see that I've just referenced kind of the classic text for biomedical ethics that is Beauchamp and Childress, that reaches way back. It's in its 8th edition, but autonomy, beneficence, non-maleficence, and justice are the ways we think about our patients' biomedical rights. And this can be applied very well to these softwares as well. And I'm going to go ahead and lead us through a few examples here. Just gonna keep going here. Thank you. So the first one is regarding bias. And when you think about bias, we're really talking about now unconscious bias, and it's a disproportionate weight in favor of an idea or thing. You can also have bias in statistical descriptions as well. So these are biases that you're not thinking about, but you just take in upon sight. But within the data sets, you can also think about the bias in this way. So the left picture is a circle showing the audience, and a bias is a small group of those people that can be just a selection, and you're getting not the full representation. If you think about this in AI, data sets are used to train algorithms. So if you start with a data set that's biased, it can actually not work out the way you expect. You can actually misapply that to the wrong population. It could be inadequate to detect things. And then you might, the worst thing I think would be to not question the inherent bias if that was the case. And then there's a more colorful representation here on the right. If you look at the whole population and the data you use, you can see if you were only training a data set on red and yellow dots, you wouldn't even know there were blue dots in your data set. So that's obviously a huge risk for bias and a consideration when you're looking at any AI tool. This is definitely a spider web of different places where this is about trust in AI, and the orange boxes are what I was talking about before with kind of not recognizing limitations of your data. And then you can see biased data, incomplete data. But just a number of things have contributed over time to us being concerned about the AI applications of data. The other consideration is this chart, which is very familiar to those of us, shows where we are with AI. And over time, different populations and different softwares have moved up the innovation trigger to the peak of inflated expectations. And over time, you'll see that those usually kind of fall down and say, you know what, I'm a little disillusioned. After a couple of years, some of these technologies might not be as great as we thought they were. And then you move eventually, hopefully, into the plateau of productivity. So you can see that our AI and informed AI is just starting up that cycle. So definitely the right time to be asking questions. This one I think is funny because just a reminder that even though in healthcare we're sort of struggling about which are the best ways to use this and the most fair and equitable, in other places it's just very pervasive. So here's your Alexa looking to sell you funnel cakes here as you go. So if you think about all of this in healthcare and you think about the public perception, there's actually a fair amount of acceptance of AI in our everyday life. If you think about how Amazon predicts what you're going to need next, or your bank reminds you of things, or your fitness tracker is going to check in with you in an hour and say, make sure you stand up and walk around. We're fairly accepting of these. And then I even added in here for COVID test results and vaccinations in our current public health status. We're pretty accepting of that. We like automation to say, hey, you had a contact trace and here's the nearest place to get tested and screened or hopefully get your vaccination. But if you actually look at some of what's been published in the past, you'll find that a lot of patients, 63% of the adults at least, were uncomfortable with the idea of their personal data being used to improve their healthcare, and they don't want to use it. Patients don't value this study by Chiara et al. Really said in a survey of patients, patients said, why should I pay equal amounts for something that a computer is going to do automatically versus something that a human may provide? And so it's really interesting, this gap that people have in their understanding and their willingness. So hopefully this is working better on your audio, guys. Sorry about that. So I'm going to go ahead and move us into case studies. And this really is the part about applying those good questions that we hope to see. And I have a couple examples here that hopefully will resonate with you all. And I should go into this saying the goal is not to discourage the use of these technologies. They have immense promise. The goal is really to start thinking about how we question and look for things like our red flags. So you'll see a few red flags throughout these descriptions. So we will go ahead and we'll start with kind of a simple one. What seems kind of simple compared to some of what we've been talking about. We'll start with pediatric sepsis. So a topic near and dear to all of us as pediatricians. We know early detection and intervention is key to good outcomes. And we actually have huge, well-validated positive outcomes for that based on big data sets. These are published data sets that we can look at, and we can examine each other's data sets to say, is this representative and inclusive? So for example, if you are basing your algorithm on a data set just of children from urban areas or a certain socioeconomic class or even age group or predisposition, that could be an example of a bias in your data set. Those of us that work at children's hospitals, we tend to get children that present fairly ill, right? Our case mix index is very ill. So you really want to think about that. But the other part is there's lots of tools to utilize. I've just extracted kind of this Sears criteria that's from one of those tools I mentioned. So good things about a pediatric sepsis algorithm is that you can actually also, remember that earlier quote about can you biologically observe what the algorithm is telling you? And in this case, you can. Lots of good objective findings about whether a child has sepsis or not. So the red flag is just around the representative and inclusive data set. You want to make sure any algorithm you are using based for pediatric sepsis has that included. So I kind of walked you through these already, but for ped sepsis, most of the algorithms are being written by humans and can be double checked by humans. So if you said, okay, I want my sepsis trigger to be for this white count and this temperature and this heart rate and this age, those are all things that our brains can check against. If we started to use an even bigger data set, which has started to emerge in things like, you may be familiar with things like a Rothman index or something like that. Those are harder to observe because we don't see those as much. There were no buzzwords in the pediatric sepsis algorithm, but that's definitely still a tool we want to think about. So the other part is if you are using an AI pediatric sepsis algorithm, you kind of want to be vigorous and look at the outcomes once you apply it pre and post. If you put in this algorithm, which is what we did at our institution, we actually took an algorithm that had been validated in other children's hospitals, implemented in our EMR, and then as part of our ongoing QI, we said, are we adhering to it? Did we detect more kids? What is going on here? Then it actually works out pretty well in terms of that check and double check. The questions you might want to ask: do we consent patients separately if we're using these tools? We do not, right? We consider this algorithm pretty well established and we don't consent them separately. Are there any unique risks or benefits? Well, for ped sepsis, this particular built-in has a pretty close connection. It's not making decisions or diagnosing on its own. So there's not really an additional burden of risk. And then should or can our patients be allowed to opt out? And in this one, we don't. And it's for all those reasons I just mentioned. However, if you start to move into other areas, so say you're starting to look at behavioral health, and here's a very pensive robot thinking about things. What if you were trying to use an algorithm to analyze or describe your therapy sessions? Should raise some questions about, do we have to consent for that data capture using the virtual scribe? What if it was making a diagnosis for you? What if then these are real studies that have been published where AI was used for both analysis of the therapy session as well as a diagnosis of bipolar disorder. The questions we should be asking: is the data set being used to train the tool inclusive, or what's the inherent bias in that trained data set? These are not to say that these tools aren't of benefit to patients. And in the area of behavioral health, where the need is so great, we do want to try to automate it. However, we want to also be just very thoughtful as we move forward. There's a behavioral health actually has several. There's a study as well for delivering cognitive behavioral therapy. As a parent or a pediatrician or a child, how would you feel and how would you talk about getting actual therapy delivered via one of these softwares? And is it being effective or not? And again, also, there is a lot actually in the efficacy of therapy sessions, trying to, and it's not for bad reasons, right? People are trying to say what makes for effective therapy and how can we do it better? But does the patient have the right to decline that? These are those good questions that were raised both in these studies and that honestly a lot of us are facing in our everyday work because there is such great need for these services, and we are not going to be able to churn out, hundreds and hundreds of clinicians to meet that need in the way that we did before. So a lot of pressure to adopt it. The references are here. They're just fascinating reads about how people have started to use these technologies in behavioral health. So a few red flags. Measuring efficacy of therapy is honestly very difficult even without AI. There is a presumptive removal of the bias that that we really can't account for, really. If we think back to those other questions that we said earlier, how would you remove the bias from this? This is one of those areas where the actual technology and software can't really be checked against a gold standard for human behavior. It would just be almost prohibitive to try to have someone observe and reflect and gauge a transcript of a session versus the way an NLP software could do that. The potential equity issue, I think, is a really important one as well, because if the choice is between offering an AI-enabled service versus not having that service at all, ethically, how could you get the patient and in the case of children, their guardian, to really understand the risks and benefits? I actually think this is a very good question and a very good moment to kind of push it, because in the past, medicine has not always kind of done shared medical decision making quite as openly as they could have otherwise. So in these cases of behavioral health, again, I'll just go back for a moment here. If you have a number of children in your waiting list for your behavioral health clinic, it looks like ours does here in Indiana, it's the idea of being able to offer something that is not harmful, so non-maleficence, it's not a harmful thing and could actually help, is certainly something that I think people are willing to consider more openly than they would have in the past. However, then it just begets more questions. How are you going to support this and make sure that patients know what is going into it, they know their privacy and their rights in order to make that an informed decision? Oh, this is just a reminder. This is if you are a fan of science fiction, you might notice this this medical droid from the original Star Wars films, who treated Luke Skywalker on the planet of Hoth. And what is hilarious and interesting is, what starts as science fiction is only that way until it becomes a science reality. So just a reminder, I put this little 2IB here just to remind me, computers and software programs, they don't get tired, and they don't do things differently. They will do things the same way each time once you establish the rules for them. And in that way, the way they deliver care, even in something like behavioral health, is can be more reliable as long as, again, you understand how their data set's being trained and what goes into it. So it's really very much a balancing act. So it's just a reminder, robots and computers don't get tired. So moving on to our next use case, is just dermatology. This one is also very promising because this is another area where access can be a big challenge, and also where we've seen a real boon, the potential of telemedicine and virtual consults. What I've pulled here is actually just a few months ago, Google revealed some AI tools that they want to use for dermatology. And so they're pulling from the fact that there are a ton of Google searches every year related to these dermatologic findings, and there is a huge shortage. So at Google Health, oh, there's a red flag here for me to remind myself that those Google searches and that data is proprietary to Google, right? There's not like a there's not a lot of cross collaboration, double checking that data in those searches. And then you also have the global shortage of specialists, so you have the added pressure where people might say, well, is this as good as an unrefined or curated search? So what I wanted to highlight here in dermatology, this is a really early example. Dermatology very early on was very powerful in the area of AI, because what they said was, if you think about how many slides or images a human brain can consume in any given day or month or year, it takes a long time to become an expert, right, to gain mastery. So what they started to look at very early on was a very, if you thought about AI predictive rules to machine learning, if you think about training a visual image or a visual model to look at nevuses and dermatomes, there are hundreds and thousands of articles trying to compare computer programs looking at those images to humans and who is more reliable. Excuse me. And a lot have shown great promise. But the slide and image I have here is actually from a 2019 paper to say that's great, because you can train a computer on thousands of images in moments versus how long it would take a human to recognize the same patterns. But a computer is also susceptible, right? We can actually confound that data, and it's actually something called adversarial attacks on machine learning, which just sounds like a science fiction movie come to life. So in this image, you can see on the left the image of what is a benign nevus, and then fed it through a computer program with a deep neural network. That means the computer and the AI is making tons of decisions and predictors that are not translatable to a human. And in the original image, the model was very confident this was benign. And then what was introduced was something called adversarial noise. It's actually something that other AI can come up with to confound the model. And the same image then produces a very confident malignant predictor. And so this is a kind of a scary thing to think about, right? Because at first you think, oh, a dermatologic model that can be trained quickly and do the same thing every time and doesn't get tired out. What a great solution for reviewing images. But then you introduce this risk into it, and you are suddenly realizing that you've got other things at play. How you even detect this. Now the computer programmers are looking at this adversarial noise and having to think of ways to address that. And it's not just visual. It's not just visual. You can actually have the same kind of risk in things that are risk assessment tools. So I'm going to go ahead and move into what is probably one of the more prominent cases, which is risk assessment. This one sounds like a really good one. This isn't diagnosing skin cancer or predicting sepsis. This is saying who among my patients are going to have the greatest need. And this is an example, a use case that is a very commonly used tool across over 200 million patients in the US every year. And what they do is they apply this tool and they look at all of these demographics and other predictors, and they try to find patients who will have the greatest benefit. Sounds like a great plan, right? We have limited resources. We need to get the resources to the patients that need them the most. So what they did is the researchers who went to look at this tool said, this is being used across a lot of patients, determining a lot of people's lives. Let's look at it and see if we can see how it's doing. And what they found is that the algorithm scored less healthy Black patients with similar risk scores to healthy white patients. That meant the algorithm was less likely to refer Black patients than white patients for resources. And again, I'll go back to our red flags here. This was a proprietary model. So until these researchers were able to kind of really get into it, no one had been looking to examine it. And what they found, this is from Dr. Obermeyer and his team, who studies machine learning. studies machine learning, excuse me. And what they did was they really delved into it and said, why does this even work this way? This race was not an item that was in the algorithm originally. And so this was kind of a bombshell, because this meant for 200 million patients, we were not distributing resources equitably. We were actually giving more to white patients that were less ill. And what they found was, even though race was not in the algorithm, they found that people, Black patients that were sicker, were less likely to spend as much on healthcare. And that was the predictor that really came out in this tool. And similarly, here's the adversarial attack part of this, where you could actually have a tool like this coupled with NLP scraping through the record, trying to make your billing more accurate. You can see small changes in the words. And so if you say back pain instead of lumbago, and you say alcohol abuse versus alcohol dependence, these predictive models are very easy to confound. So I want to head into kind of the home stretch here, the last part of the discussion about, well, what do we do? Because we've got these great use cases with incredible need. We want to use our technology as best we can. And we want to be fair, and we want to get patients the service they need as quickly as they can. So we have to have some process to how to do this. And unfortunately, there's no easy answer to doing this. It's really just the continued learning like we're doing here today, and continued partnerships. So I'm going to go into some examples here. I already mentioned the balance here. I want to say too that today's talk is not about trying to make you scared or worried or resist anything to do with AI, because if we don't try to help shape this, what will happen is we'll lose the chance to be innovative and think about things in new ways. So that's one side of the spectrum. The other side of the spectrum, though, is that if we make too many rules, we won't be able to question and examine new potential things. So we will have to do both of those and strike a balance. So there's been some areas about and suggestions on how we could do this. One of them is thinking about AI as similar to clinical research. So if you think about the way we look at a new drug, for example, or a new therapy, you assess the data model used. You assess the data model used for validity, completeness, bias, and timeliness. There are actually tools in place for this. You can see some of the Equitas and AI fairness. So you can assess the data. You also have to assess the skills you need to do this. If you're looking at an AI tool comparing human performance with a human task, you have to have domain knowledge to do this. You really don't want someone without healthcare expertise or clinical expertise trying to say how severe an output of a health IT application would be. And then best practices. This one is actually, I think, quite hard because developers, and this is taken from a paper by Dr. Park and colleagues that was in JAMIA last year, but I think this is the most important part here. The developer should not evaluate their own tools. If you are, for example, think about that Google Dermatology tool that we mentioned before. It's very hard when you're trying to produce something for your stakeholders or users to get something done on a timeline, and then to also be questioning it. And if your job is on the line, it's very hard to be thoughtful about this. So what this paper suggested, and I think this is a great idea, that there needs to be more across the academic, public, and private sectors, with a team who doesn't have responsibility for sales or things like that. That can really give that sort of objective review. And I have an example of that. We're going to come back to that Optum paper I mentioned before. But you also have consenting for AI risk. This is another area to think about, so that you have checking the rules themselves, and then you have consent as well. This is the part about, I mentioned for Pediatric Sepsis, we don't consent separately for that tool. But if you're going to use, maybe you're going to use some skin cancer diagnosis software. This is from a paper from Australia, actually, where they have a ton of risk for skin cancer. And this is a suggestion they had about how you might want to formulate an informed consent for AI software. You might want to say, hey, I could miss this malignancy. We might overcall it. You might want to emphasize the benefits, that it's faster. That's something we mentioned before. And then the limitations. If you're thinking about, oh my goodness, I have barely enough time to say hello to my patient, how could I possibly do this consenting as well? I don't think this is something that we can do individually one by one. I think this has to be something that we make part of our practice. And then these are kind of some more general reflections kind of within the AI and health IT community. So there is also a problem with the actual data scientist community in that we don't have a ton of diversity represented there. So there is a role in personal bias among the folks that create these challenges. There's also this idea of data empathy, which I really love because this talks about the context for data. And this is referenced in this recent article in The Lancet, but data empathy is the idea that you actually understand your data set at a deeper level. This has not traditionally been sort of measured really completely or objectively, but it is something that can help you understand the potential risk and bias that you might be facing. And then finally, I really like this idea that data scientists are responsible for tackling, this reflects racism in particular, but it could be any source of bias in the data set. I've even read different data scientists saying that, if they work in healthcare and the algorithms that they form, they really should be also providing this type of oversight, which has not always been something that's been done in the past, right? Like we share data sets, et cetera, but we've not always held each other accountable. This is Dr. Obermeyer, and I'm going to go back to this because this is the example. Remember the risk assessment that had some embedded racism that we noted earlier. And what happened was that Dr. Obermeyer and his colleagues did publish the study saying, look, this risk assessment tool is disproportionately spreading resources. It is not sharing them in the way that we would hope. And so when they did that, they actually didn't just stop there. They actually said, you know what, we're going to work with the people we investigate to help improve their outcome. Additionally, there's been more attention to paid in areas like the AHRQ, which is Healthcare Research and Quality, saying, where are we looking at this? How are we doing this? So really raising the profile, because it's not that we're going to throw out these algorithms and tools. It's that we're just going to have a new standard to detect ethical concerns as well as bias. Dr. Obermeyer and his team have a reference here that they publish. You can click on the link and go look at it at any point in time, but it's an bias playbook. So in addition to those good questions and the red flags that I've been referencing in our case studies, you can see here that we've got kind of some good questions here in his format. And what I really love about the table is this idea of ideal and actual targets, because I don't think we talk about that very openly. We use a lot of surrogates. And here are some examples, and I'll go ahead and pull out the example of the clicks mobility score, because this one it's not one we use often in pediatrics, but it's certainly one that is very, very prominent in assessing our patients with chronic morbidities, excuse me. So this can change where you go home, this score, this third line. You can change, are you going to an acute rehab facility? Are you going to your own home? And it's about measuring ADLs and independence. That's what it's supposed to do. But what it actually does is just measure physical mobility and daily activities. And so if you have, looking at this score all the way across, the same physical mobility scores are really disproportionately represented for those that are lower socioeconomic incomes. So that could change the disposition if you're using this. Does this mean you shouldn't use the score? Not necessarily. It just means you have to have some controls in place to make sure you're checking your outputs. And then I'm going to kind of spend a bit of time here. If you remember that hype cycle that I was talking about at the beginning, where we're rising up the peak of heightened expectations, there is an incredible amount of fatigue among all of us in healthcare. And what is really worrisome is the idea that we are so pressured and so much under so much pressure to scale and adapt and do more with less, that we might be willing to accept less than ideal circumstances for some of these tools. And I don't want you to walk away thinking that you can't use these at all, or that there's no promise, because there is immense promise. But I think what's incredibly important is that we have the same sort of fortitude, insight, and discipline to what we're looking at in these tools before we adopt them, and not just do it because we're tired or fatigued. If you have seen the movie Big Hero 6, you'll notice Baymax is the hero, one of the heroes of that, shown above, and it's really not just a matter of time before we start to see what is in science fiction become reality. You can see in the movie below, you can see a very Baymax-looking kind of robot who's actually deployed now in Asia to assist with mobility. This robot does not get tired. This robot will do the same task over and over again. And if you've seen the movie, you'll remember that this comes with incredible, he doesn't even get compassionate fatigue. He actually is relentlessly compassionate and committed to his mission in the movie. And that is something that, just on a personal note, I think a lot of us are feeling that fatigue. And so I kind of feel that there is an incredible amount of value to this technology. I just think we have to be very thoughtful about it. I have a small plug here at the bottom. You'll notice the AAP, which last year celebrated its 90-year anniversary of caring for children. As Dr. Suresh mentioned in the introduction, I've been really privileged to work with the AAP in this area of clinical technology, and are working on the group is continuing that are AI specific to children, so that we can have a consistent way that we lean into embracing the positive things about these softwares and technologies, while at the same time keeping the balance of watching for particular ethical concerns and biases that might emerge, which is really key to this. So that brings me to kind of the formal conclusion of some of those case studies and my formal slides. And I'm really hoping that this was helpful in thinking about how you look at these tools. There's a number of references that I'm happy to share, and I think you'll all have access to. And I will, thanks for the chance to share some of these ideas, and I hope there's some good questions.
Emily, thank you so much. That was truly awesome. I was taking notes, and you and I have chatted a lot, but still learned a lot of new things. The good questions and the red flags, I think that's a very practical checklist to use as we deal with narrow focus applications, pediatric sepsis, etc. So thanks for the template. Otherwise, we're just looking at papers and manuscripts and thinking, how we can translate this. Just having practical points certainly helps. And then one other comment, before I'll open up for questions, I have like 6 questions, so that's good. We'll get to all of that. The table where you showed the algorithmic bias, I couldn't help notice there was one line, the 4th line, like one line below the 3rd line, 3rd row that you highlighted, was on no-show predictors for clinic visits. So we actually have one here, but it struck me that I don't know the background or the secret sauce that went into it. So, and I think other leaders also don't know. So something for us to know, for a tool that we are actually using it to predict clinic no-show visits, but how was it built? Did it take the right data set into consideration? Going back to your slide on red and yellow dots, and where are the blue dots? Did they get missed? Or did we miss the blue dots while we created the thing? So,
and actually that one, that's a great example. I could have called out the no-show rate. That one has been like a classic one, right? Because you're like, well, if people are no-showing, then what am I going to do to try to prevent that? Because they're taking up a spot or they're taking up someone's access. I will say, Suresh, if knowing that we work on similar technologies, that particular vendor, if it's one that is from our EMR, they've made it a big commitment to look at that tool and to understand more deeply the data sets training it. And so I think that's what has to happen, because it does, as you might imagine, it does select more often and predicts no-shows more often for people that are kind of a more poor and poverty common denominators, because for the reasons that you might expect, it's harder to get off of work. It's harder if you have to take the bus versus can you drive yourself there, et cetera. So that's a great example. Thank you for that kind of pre-question.
Good for us to follow up on. All right, I'll get with the questions. Dr. Radovich from Division of Adolescent Medicine. Thanks so much for this talk. I'm wondering, do you think we'll be able to use AI to learn about ourselves and our own patterns? For example, will we learn more about the art of medicine and our own medical intuition? It seems this is something we expect, expertise, even when it can't technically be checked. Your thoughts?
Yeah, I think that's a great one. And I maybe that I used because, and I'll share a story. When I was in training, when I was in medical school, our medical school actually did a videotape of you kind of talking to a patient and then had you critique your own behaviors. Like, I'm doing it now. You can see me gesturing. I found that I use my hands a lot and I tend to talk faster when I'm either excited or worried or something like that. So if you think back what I did in my training versus what they're doing now, and probably the best example would be therapy in behavioral health. I think there's potential there. I think that behavioral health has so many other factors than what is only observed in language and even kind of that presence. I'm worried about that one kind of giving positive feedback because it seems so dichotomous, good, bad, efficacious, not efficacious. So I think in terms of learning about ourselves as physicians, I would say that we're probably more robust and able to apply it to more objective decisions, similar to some analysis about which physicians are more likely to do things like, I don't know, adhere to Bright Futures recommendations, or on the adult side, like US Task Force, who is more likely to prescribe medicines or order or not order studies in the appropriate, those kinds of objective markers, I think are probably easier for these technologies than something that still feels a bit more akin to more subjectivity, like a bedside manner or how you express yourself to a patient, if that makes sense. I think huge potential there, but again, I kept saying I don't want to discourage people from using the technologies, but I am a little bit of a skeptic. So I still like to look at the tools where I have more ability to understand it, kind of that biologically observed, versus something so far down the line that there is no way for us to gauge its relevant accuracy. So great question. I think it's going to keep coming.
Sure. I'll get to Dr. Loretta Mateo. She has two questions, and Loretta's from the Division of Adolescent Medicine, and she also oversees our DEI initiatives for the department and for the hospital. Her first question is curious about the 63% of patients not wanting AI to be a predictor in their illness. Was curious about the age distribution. I'm assuming the younger generation who are growing up with Alexa will be more accepting.
No, that's a great question. Thank you so much, Dr. Mateo. A study, the 63% was adults. And what was interesting, it wasn't in the adult population. The other thing it called out in the comments in that paper, and that I think probably won't surprise everyone, is that the reason people kind of, some of the things they said, patients said, is they didn't like the idea that it wasn't personal, like that it was not connected to who they were. And I feel like I'll be honest, I wasn't expecting to read that in an informatics paper in an IT journal, this very visceral, very personal idea that you are not, you are more than kind of the sum of your objective medical problems. I think culturally is the other part, not just age distribution, but culturally, perhaps in the United States, we tend to have this kind of individualist, kind of non-predetermined culture. And so there was a lot of resistance to that idea that you could be predicted to have an outcome a certain way that was very separate from you. So, so that was that one. I think it's interesting because I'm a parent myself. I have two kids, and I think Alexa's part of our life. She reminds us of things, she tells us of the weather, but they have a healthy skepticism as well about what they're willing to accept from her versus versus otherwise. So I actually wonder if we're seeing in our young adolescents and youth a healthy skepticism. I'm very hopeful that will continue.
Got it. Thank you. One more from Dr. Mateo. What are some specific interventions being done on the issue of racial bias? Are our various medical organizations, AAP and the like, leaning in to assure we are not overlooking this on a systematic way? Is that a medical AI professional organization?
What a great question. And Suresh, I'll ask you to help me answer that one too, since we leading up to this had some discussions. But I think that the last 2 years have really forcefully described how we have to have systemic racism and racial bias as part of our medical curriculum, just kind of generally overall. Medical organizations, and so the AAP, I mentioned we're working as a group on sort of a policy statement. I do not think that there are a lot of solutions, to be honest. I think if there was one, I shared that algorithm bias handbook because it's one of the ones I've found that's available. I mentioned the Aquanimidus and some of the free AI assessments, but there is no one yardstick to say bias or not biased. I truly do believe it's kind of about weaving together people who have the tool. They say that doesn't mean we can't not use them. We just have to really emphasize trying to understand them. So there is, to my knowledge, different, I would say for the part about there's not one society that I would say. I think a lot of professional societies have an AI and honestly kind of an ethics arm. Would you agree, Suresh? I'm not personally aware of one AI organization.
Yeah, you're absolutely right. There is no single, going back to Dr. Mateo's question, single medical AI professional organization who has put out a position statement or a policy which is binding or at least applicable to all clinical specialties. The AAP is certainly looking at something like that. As both of us know and working on it, and even the AMA hasn't come up with a very clear statement. A couple of years ago, there was a Senate bill. I've looked at the very tentative version. Again, that's in Pennsylvania. So this may vary across states. There is also industry pressure. It is what it is. Health information technology is very, very tied to the technology industry with the big names. So that also plays a role. But yeah, no easy solutions.
And the other way I might answer that is that although might not be a professional organization, I mentioned the AHRQ, and I mentioned some of that regulation as well. It doesn't sound glamorous to be like, well, maybe we'll have a new law, but I think kind of coming on the heels of some of our other health IT laws, I think right now would be a really good time to, I mean, the momentum's there. And so I love the question. I love the optimism there. I actually think this would be a good time for us as physicians and medical professionals to really come forward with saying, hey, look, we know systemic racism impacts kids and kids' health. And we also know that we need these tools. So let us be part of those laws and regulations, because I'd much rather people that are living with both the benefits and the consequences be helping shape that. So
absolutely.
Great.
Thank you. One more question. Can AI be used to identify bias in studies, both retrospectively when assessing results and conclusions of studies, but more importantly, prospectively in study design?
It's a great question. So I think that's a great two-parter. I love the prospective study design, because there are some ways to look for bias using kind of automated rules, right, that you have control over in your data set. You can kind of look to a data set and say, where are my gaps in training? And I'm not a statistician, so I will defer to my colleagues who are in health services research much more savvy on that. But retrospectively, that's what Dr. Obermeyer's paper and kind of that big one around risk assessment did. Now, that's not something that I learned in my med school classes on. It's not a 2 table. It's something that you would want someone who's very schooled in NLP to do. And to look back, I actually think that's a huge area of potential. Like if you think of big studies that shape and shape the way we do the medical decision making, I think we're going to have to be very comfortable as kind of rigorous scientists in questioning some of those outcomes. I think forward looking, there's not a lot of silver linings for the last 2 years, but in terms of the COVID vaccinations and COVID testing, we have really it's not even a burning platform. It's like it's burning all around. It's an inferno for a large data model like this. And I think what you're seeing is, I know the public's kind of uncomfortable with it, but like you're seeing like people coming forward saying this sample, this, we've got a biased data set because perhaps in your city you're not vaccinating as many people of color, et cetera. I think it's a learning lab right now to kind of prospectively call it out. And it's really interesting, I think, for people and the public in general to kind of see our dirty laundry. This morning that we can use these tools moving forward in a way that really highlights the transparency we need to make them accurate.
Thanks, Emily. I have 2 questions, and we have 4 minutes, so I'll squeeze those in. One is, you can put your, CMI or hospital administrator hat on. Cost. As we know, health information technology is expensive and getting more expensive. These AI tools, however beneficial they are expensive. How do you balance that in this era of still we're not fully at value-based care yet?
Yeah, no, that's a good one. I have 4 minutes to try to solve that one. That's a good one. No, I think that the cost of overall technology in supporting healthcare is rising, right? I mean, think about the things, heaven forbid you have to go offline or not have the connections you need to provide for care. There's also a lot of things we have to do to keep it safe. If you look at even something, we even talked about cybersecurity, just basic cybersecurity. So the cost is increasing, and it's not just the cost of purchasing software, it's the cost of building skills and a team that can manage it. So I don't think I think people still are thinking about the software like, oh, here, I'll buy this software and that will solve the problem. But it's really not. It's really a more expensive investment even than bricks and mortar walls are. I think the trade-off, to be kind of curved too, we're not yet getting rewarded for adopting these kinds of technologies and not necessarily being incentivized to use them that are in the manners we've just spent the last 45 minutes talking about. The very rigorous manner we just example. Pediatric sepsis is one where it feels like such a slam dunk. If you have some kind of predictive clinical decision support in place. And I think that's what we'll see more over time, rather than an all or nothing. There will be some things that will move forward and be so obvious benefit to patients, it will be an expected standard in our technology. There will be others that will be lagging, but I think that's what we'll see over time. And then what I hope we'll see is that it won't be a matter of choosing which one, but I think it's pretty well established that we're not going to be able to just keep adding people and resources. We're going to have to figure out how to use some of these tools to automate and scale and reduce some of these cognitive burdens in ways that are smart and responsible and make sense. So,
thanks, Emily. You answered my last question too, which was training residents, fellows, and junior faculty, etc. Formal training, things like that. But you said the investment is not just in the software; it's in training people. So if dollars are being spent, it has to be set aside for training end users too. So
yeah, and not just this is way beyond clicks in our EMR. This is like understanding, I think, quality and safety, and understanding financial burdens in healthcare. I think this is going to be a big part of all of us moving forward.
Awesome. Thanks again, Emily, and for our attendees, thanks for joining in. And just letting everybody know, Dr. Weber is actually on vacationing with the family, but took the time off to talk to us. So much appreciated. And we are close to 100 participants, and thanks to everyone for joining. And for those of you who have the time to join for an informal meet and greet, there's a separate Zoom link which Colleen put in the chat, and feel free to join us. And even if you have any questions for Dr. Weber, her email was on the last slide, or you can reach out to me and I'll pass on the questions. Thanks again. We'll adjourn this session and then in a few seconds, join the separate meet and greet. Thank you.
Thank you so much.